Good morning, and thank you for coming today to the briefing on a new supplement to the Cleveland Clinic Journal of Medicine on optimizing home health care, enhanced value, and improved outcomes. My name is Teresa Lee, and I'm Executive Director of the Alliance for Home Health Quality and Innovation. The Alliance for Home Health Quality and Innovation is a nonprofit foundation dedicated to research and education about the value that home health care offers to patients and the entire U.S. healthcare system. We're thrilled today to have partnered with the Cleveland Clinic Center for Continuing Education to co-sponsor this journal supplement on optimizing home health to enhance value and improve outcomes. The Alliance is proud to sponsor this peer-reviewed research publication, and I'm pleased that the articles that you find in the supplement are authored by highly regarded thought leaders in medicine and home health care today. The initiatives and innovations you will hear about in today's briefing represent some of the exciting work underway in home health to improve patient care and make our healthcare delivery system more efficient and effective. We're pleased to be joined today by the President and CEO of VNA Health Group, Dr. Steve Landers. As a co-editor and author of the supplement, and as a leader in home health care, he is uniquely qualified to guide our discussion. More recently, we've been excited that Dr. Landers also became the Alliance's board chairman. Before I turn it over to Dr. Landers, I want to thank everyone who is participating today in today's event via our live webcast. And if you are on Twitter, please follow the conversation with our hashtag #OptimizeHomeHealth. Please welcome to the podium Dr. Steve Landers.
All right. Good morning, everyone. It's a real pleasure to be here this morning. And Teresa, thank you so much for all your efforts on behalf of the Alliance to bring everybody together this morning for a really a special event. And thankful to you and the whole team that worked hard to get us all here. As Teresa Lee mentioned, the Alliance is a wonderful organization dedicated to research and education in the home health sphere, specifically looking at opportunities to improve value and improve how we help people at home in the future. And that's, for me, really the reason why I'm here as a family doctor and a geriatrician who spent some of my practice working in the home and community, knowing that we have really across the country millions of patients and family caregivers that want to remain at home in spite of tall odds in some instances. And this is an opportunity for us to better understand how we can optimize the care that we deliver to help more people stay home, which I think is a really important thing for us to be looking at, both as a sector of healthcare providers, also as a country in general. This is one of the challenges we face with the demographics. I'm honored to be here with my distinguished colleagues, a number of whom are from my former home at Cleveland Clinic, which is just a wonderful organization that has been working very hard to make sure patients get care at the right place, in the right models, using the right information systems, and it's really an honor to be with them, and also to represent my current organization, Visiting Nurse Association Health Group of New Jersey. This is a nonprofit statewide home care and public health organization. Interestingly, for our time in Washington here, it was founded 100 years ago by Geraldine Thompson, the first female delegate to the Republican National Convention, who was also a childhood friend and co-reformer of Franklin and Eleanor Roosevelt's. And so they had a bipartisan effort in improving the lot of migrant workers and child laborers and people living in the shadows. And today I think it's neat for us to have sort of a bipartisan attitude toward how do we help more people stay healthy at home in spite of chronic diseases and other maladies that they face. The supplement was co-edited by two of my colleagues at Cleveland Clinic, Dr. Bill Zafro and Cindy Vunovich, who's a nurse executive responsible for much of the home care programs. And I want to thank them for their for their help. What we'll do, for the rest of the briefing is go through a presentation and discussion of the contents of this really exciting supplement. The neat things about this are, one, this was a peer-reviewed journal supplement that's certified for continuing medical education, all focused on how do we improve value, improve outcomes in home-based care. And that's exciting. This is a contribution, by and large, from the Alliance and its members, which are members of the home care sector. Some call it the home care industry. I call it the home care movement, if you will. And this is the time and resources that our sectors put into this. And I think it's a good contribution to the medical literature and to medical education, and it'll help us move forward in healthcare. Without any further comments, I want to introduce Dr. Gorodetzky to briefly welcome everyone on behalf of Cleveland Clinic and Cleveland Clinic Journal of Medicine. Dr. Gorodetzky is the director of Cleveland Clinic's new Center for Connected Health. He is a board-certified internal medicine cardiologist and heart failure and transplant cardiology physician. He's responsible for supporting Cleveland Clinic's home care services, at-home hospice care, mobile primary care medical practice and nurse practitioner practice, and skilled nursing facility programmings. In addition to being a panelist, Dr. Gorodetzky is an author of one of the interesting articles in the supplement. So without further ado, Dr. Gorodetzky.
Thank you very much, Dr. Landers, and thank you to the Alliance for giving me the opportunity to write one of the articles and to come to this panel today. So on behalf of the Cleveland Clinic Journal of Medicine, I'm very excited to release today this supplement called Optimizing Home Healthcare, Enhanced Value and Improved Outcomes. The Cleveland Clinic Journal of Medicine is a peer-reviewed monthly medical journal that provides readers with practical and clinical information relevant to a variety of healthcare fields. The journal focuses on timely content that has continuing education orientation and features authors from the Cleveland Clinic as well as prominent other thinkers from around the country and the world. As you'll see by this impressive group of panelists today, the authors were chosen for their clinical experience and expertise, both in clinical fields and in research related to these activities. In releasing today's supplement, the journal is pleased to partner with the Alliance for Home Health Quality Innovation, highlighting the increasing valuable role of home health in strengthening our healthcare delivery system for the benefit of patients and payers. So thank you again for letting me be here today and be a part of this discussion, and I'll turn it back to you, Steve.
Thanks so much. It's a pleasure having you. And without further delay, I would like to introduce our remaining panelists, and I think you will have a really worthwhile conversation about home-based care and helping people stay healthy at home. Right next to me is Dr. Michael Fleming. Dr. Fleming is a family physician who serves as the chief medical officer for Amedisys, a national leading home health and hospice company. Dr. Fleming is a past president of the American Academy of Family Physicians and the Louisiana Academy of Family Physicians, and he was founding president of the Louisiana Healthcare Quality Forum. He also serves as a founding director, chairman, and chief medical officer for Antidote Education Company, which provides continuing education for healthcare providers. Welcome, Dr. Fleming. Next to Dr. Fleming is Dr. Peter Bowling. Dr. Bowling is the chair of the Division of Geriatric Medicine at Virginia Commonwealth University in Richmond, Virginia. Dr. Bowling has dedicated his career to creating and championing high-quality, compassionate care at home. Those of us like myself that do home visitation as part of our practice have really looked to Dr. Bowling for leadership at a national level in terms of advancing the role of physicians and advanced practice nurses in the home as well, and it's an honor to have him. He started this real passion for him in earlier in his career when he saw unmet needs in geriatric care in terms of the need for home-based care, and he was responsible for increasing the Medicare fee schedule for physician home visits to make it feasible for more physicians physicians to actually get out and see patients at home in the community in 1998. And a lot of the increases that we've seen in physician home care in recent years, that's because of Dr. Bowling's advocacy efforts. He was part of a small group that worked tirelessly to have the Independence at Home Act included in the health reform law, and is now being implemented as a demonstration program throughout the country, and has spoken extensively on the physician's role in home care, as well as authored numerous articles. And it's an honor to have Dr. Bowling with us. Next to Dr. Bowling, we have Dr. Mark Froimson, who serves as the president of Euclid Hospital in Northeast Ohio, and he's currently president of the Cleveland Clinic professional staff. He's an orthopedic surgeon, a member of Cleveland Clinic's Board of Governors and Board of Trustees, and vice chairman of the Orthopedic and Rheumatologic Institute at Cleveland Clinic. And in this capacity, he's charged with developing and overseeing the Institute's patient safety and quality initiatives. He's also the incoming chair of the Health Policy Committee of the American Association of Hip and Knee Surgeons. And we're very happy to have you, Dr. Froimson. Dr. Gordetsky, we introduced. It's also a pleasure to have Margarita Labson, who's the executive director for the home care program at the Joint Commission. As we know, the Joint Commission plays an important role in ensuring quality health care services throughout the country. In addition to coordinating the home care business development team, she also is responsible for strategic development and tactical operations of the home care accreditation program, and specializes, her focus in her career since the late 1970s has been on home care services, and has extensive knowledge of the legal, regulatory, and accreditation requirements for home care providers across the health system. So it's a great pleasure to have Margarita. Now that we have these introductions, it takes a lot. These were pared-down introductions, I want everybody to know. That we had to be selective in what we shared about our distinguished panelists. And now we want to move into a more meaty part of our program, where we allow the authors to share what they, in many instances, they're representing a group of authors or colleagues that they worked with in this supplement. So without any further delay, we'll just go really from left to right with Dr. Fleming. Thank you.
Thank you, Steve. Hospital readmissions are receiving increasing attention these days because of the cost. Among Medicare patients, 15 to 20% will experience readmission within 30 days of discharge, and various studies have shown that up to 27% of those readmissions are avoidable. Especially elderly patients and those who have multiple chronic diseases are vulnerable at the time of discharge, and we found particularly within the first 72 hours after discharge. When the transitions of care from the facility are not managed well, whether it's communication, lack of appropriate follow-up, that can drive visits back to the emergency room and subsequently hospital admissions, again, many of which are avoidable. So Amedisys developed our Care Transitions Initiative around focusing on this particular area, particularly the 72 hours around the time of discharge, to see if we could find a way to effectively hand off the care, seamlessly hand off the care. And seamlessly is an important word because we are all aware of the fragmentation within our healthcare system right now. So our Care Transition Initiative has 4 specific components that we developed from a lot of research work that was out there, particularly the work of Dr. Naylor and Dr. Coleman, respectively. The first is to place a care transitions coordinator within each facility. These are nurses, and their role is to see the patient early as possible, hopefully 24 hours before discharge, and to begin to develop the relationship with the patient so that we can prepare the information. That care transitions coordinator evaluates the medicines, the diagnoses, and begins the second piece, which is the engagement with the family, patient, and the caregivers that are going to be there. And that engagement is coaching. It's talking about the specific disease, beginning to talk about diet, about activity, and also about certain red flags and warning signs that their disease process may be re-exacerbating. The third thing is medication management. Our care transitions coordinator is able to review the medication list as it is in the hospital, and then again seamlessly hand that off to the nurse who will see the patient in the home, and to then clearly again communicate with the patient and family. And finally, the fourth piece is hugely important, and that's communication with the primary care physician. We know it's important that that patient see a primary care physician within a week of discharge in order to prevent readmission. However, frequently the information from the hospitalization can take weeks to get to the primary care physician. So this clinician, the care transition coordinator, prepares a transmittal information that includes medications, tests, diagnoses, and all the other important things to make sure that the primary care physician has this immediately at the time of discharge. We tested this over a 12-month period at 3 centers around the country. And in the last 6 months of that 12-month initiative, we saw the average readmission rate drop from 17% to 12% on a 30-day readmission rate. The challenge now and continuing to go forward is going to be effectively managing chronic disease. That's the problem we all face. And so effectively managing chronic disease is going to depend upon the way that all of these pieces work together, the communications and, if you will, the handoff between each of these. So we believe that this initiative created a patient-centered approach that can be successful in preventing hospital readmissions and improving quality of care.
Thank you, Dr. Fleming. What a great innovation in home health care to share with us. Dr. Bowling, you're on the spot.
That's where I prefer to be, Steve. Thanks for inviting me here. As Steve said, I started on this journey over a quarter century ago. In 1984, I started making house calls, and prior to that, I thought I had things pretty well understood from the perspective of an academic health center and a primary care internal medicine residency training, and I found out going to people's homes that the model we had been delivering for these folks was backwards, actually, and that the care model is great for people that are able to get to the doctor's office real easily, but not that great if you're limited in your mobility. And things were not only adverse in terms of outcomes, but also very expensive. So I've been working on this since 1984. And we're finally making some progress, I'm happy to say. A couple things to emphasize as I make my remarks about what we're doing at VCU. The key drivers of success that I see obtained by going to the home, first thing, you know much more accurately what's really going on when you go in someone's house than if you're sitting in a hospital room or a clinic. So better information. Patient has better access. That's a key issue when you're trying to manage somebody with chronic illness and keep them out of the hospital. They need access to somebody who's going to be taking care of them. They actually become more compliant as we help them from the perspective of their home. We can figure out what's going to work. We then get better outcomes clinically and lower costs. We've had some experience with that at VCU and some evidence to support that premise. What's happened over the quarter century is home care has had this incredible explosion in terms of technological capabilities. So we go to the homes now with a laptop computer. We meet nurses with an iPad. Then both of us are carrying devices where we can measure biological parameters, blood tests. We can get x-rays in the home, ultrasounds. So we can deliver a very comprehensive, sophisticated model of care where people live, which that's been evolutionary and rapidly so. So what have we been doing at VCU? We started out with house calls in 1984. We've added sequentially a whole continuum of care, nursing home, office-based care, hospital consults, transitional care in a Naylor-type model, a PACE program, and hospice. So we have the complete continuum managed now by docs and nurse practitioners who are in my group based at the medical center but working in the community. With that, we have seen a variety of different positive outcomes. The patient satisfaction is through the roof. Our last Joint Commission survey was perfect, which the surveyor said was the first time in 1,000 surveys in 16 years she had given such a survey. We have reduced the hospital length of stay. We have reduced the readmission rate by 50%. With the transitional care program, the costs are down by more than 60%, and there's a dramatically reduced number of days in the ICU. About 60% of our patients die at home when they prefer that, compared with a 25% national average. And so overall, we feel like we're doing the right thing, better care where it's needed at the right time and at a lower cost. this observational data that we have conforms to what's in the literature. So the VA home-based primary care program, as a for instance, Mary Naylor's work, another for instance, have systematically demonstrated this type of achievable result. And these results are far more impressive than many of the other sort of biomedical interventions that we've all come to accept as a matter of course in American healthcare, on far less substantial evidence in general. So I'm hoping that we can start to embrace this type of model and really grapple with the challenging needs of the patient population, both medical and social, that we find when we go to people's homes. Not everybody's going to benefit from this, but if you target correctly and if you put the right resources in place, you can really make a big difference. What we've seen with these both improved outcomes and cost containments has been, as Steve mentioned, the foundation of the Independence at Home demonstration, which is being implemented in 19 sites around the country to test this under a CMS Innovations program. And about 3 years from now, we'll see how that has played out. We're actually hoping to have results sooner than that and move this forward into a national benefit with the support of Congress in the next couple of years. I wanted to emphasize again a couple of points about the transitional care aspect. So our patients that we put into our transitional care program, some of them we find are not actually very good at transitioning. So the idea of the transitional care model is that the patients will get better and go back to their clinic-based physician. We're finding more than 50% of our patients, when we're done with the transitional phase, can't transition, and what they really need is house calls. And so it's been a natural partnership and almost a brother-sister relationship between house calls and transitional care at VCU, which we found to be very effective. And I'm going to be continuing to advocate for the expansion of that kind of dimension, which is the medical care component, partnered with all of the other elements of home care, home health agency services, durable medical equipment, pharmacy programs, social support programs that are all necessary to take care of this patient population. You can't, no one discipline or one agency or type of provider can do this alone. It has to be a collaborative shared effort in order to really succeed. It's a very intensive service. It's relatively expensive, but it's far less expensive than usual care. And in these days and times when we need to deliver better care at lower cost, this is just the right medicine for this group of patients.
Thank you, Dr. Bowling, and the article that you wrote was fascinating. I think highlighting one of the points that you mentioned in introducing it to everybody was the idea of what you learn about people. You used the term in your article, a diagnostic house call, which I really loved that description in terms of what it means, in terms of what you can learn about a patient, how they may be managing their medications, disease self-management, their social and other environmental issues that have implications for how they get cared. Really wonderful work. I think we're at a great transition here in our panel where we've had presentations about articles in transitional care and home primary care and geriatric care models to authors who are going to share some concepts with respect to the role of home care in subspecialty healthcare services and as well as other aspects of healthcare. So Dr. Froimson.
Great. Great. Thanks, Dr. Landers, and congratulations to my fellow panelists for some exciting work I'm already learning today. So this is great. As you heard, I'm an orthopedic surgeon, and you might wonder, so what's an orthopedic surgeon interested in home care for? It's not necessarily a natural fit. But I want to share with you how we are incorporating home care into optimizing the way we take care of our joint replacement patients, and we find it to be an extremely important component. And this is critical because, as you know, as the seniors are aging, the demand for joint replacements is skyrocketing, and our ability to meet these demands really is going to challenge our ability to manage the resources that are required. And we have to approach this through new care delivery models and develop more efficient models. And as a surgeon, we surgeons have always looked at knee replacement and hip replacement as surgical procedures. And I think that this new era is starting to help us understand that these are episodes of care. And we're starting to understand that as we view this thinking to a knee replacement as an episode of care, it requires a spectrum of services, and home health is one of those. You know, certainly the surgical procedure, the implantation are important, but these additional care elements, including the home-based clinical care, have very important roles. So we took a look at that, and our research examined how home-based rehabilitation and physical therapy could be successful in reducing costs, but more importantly, improving the clinical outcomes and increasing the patient satisfaction. Patients want to be taken care of at home. You know, for patients, the end game really comes when they're home, when they're restored to their functions of activities of daily living, when they can return to work, and these transitions are really important. So what we really aimed to do was identify how we could create new care pathways that help these patients achieve these goals and do it in a clinically effective way. So one of the things that I think is common to these themes is patient engagement and shared decision-making. And so we like to get the patient involved up front and really get them to share our vision that all of us want to return them safely to home as soon as it's feasible, and that the word safe is really what's out there. And home care enables that. You know, there's considerable evidence, and we did some look at this, that the transition from the hospital care to post-care has been significantly undermanaged for this patient population, and we found that there were significant opportunities to do a better job and develop programs to identify those post-acute venues that would make the most sense. So we took a look at some of the literature and found, both with our own experience and other studies, that in-home rehabilitation care is a viable and often preferable option for our patients recovering from a knee replacement. So recognizing this, we developed what we call the Rapid Recovery Care Plan, and that incorporates an integrated approach to the acute and post-acute care with this increasing emphasis on getting patients home. So one of the tools that we use is actually the pre-call. So when we educate our patients ahead of time, we have a home care nurse call them and make that appointment for their visit immediately after discharge. One of the things that we found was that patients entering the hospital often felt they had a one-way ticket and didn't really have an excellent plan of care as to what was going to happen when they got home. And so this initiating this at the outset really helped our patients get comfortable with the idea that they were going home. Now, this plan has allowed us to embark on some innovative payment schemes with Medicare and others, so that we're looking now at this entire episode of care in what's termed the Bundled Payment for Care Improvement Program. So we have initiated a pilot with CMS through this CMMI Innovation Program to test this hypothesis that we could actually deliver better care through this integrative approach, of which home care is really a hallmark. And what we have found in our initial phase, and we've embarked on this over the last couple of years, is that since incorporating this post-acute home care program into our protocols, we can find measurable improvements in reduction in hospital length of stay, improved and increased discharge to home rates, and lower readmission rates, as well as better patient reported outcome metrics. So we are very enthusiastic about this approach because it's a patient-centered approach, involves shared decision-making, and we think it's really a feasible model to incorporate home care and has both patient-centered benefits as well as economic advantages. So thank you.
Thank you, Dr. Freumsen. Dr. Gordesky.
Thanks, Dr. Landers. So at the Cleveland Clinic, I play two roles. About half my time I spend practicing cardiology, and the other half of my time I'm the director for the newly founded Center for Connected Care, which is a center that provides oversight for various post-acute care operations, most prominently our home health organization. My path to this point has been interesting, and it's not anything that I ever anticipated doing. When I embarked on my training to be a doctor, I went to institutions to become a specialist, and not just a specialist, but a super specialist. My area in cardiology is taking care of people with advanced heart failure. And as I was going through my training, towards the end of my training, I really recognized and realized that probably the most intensive and interesting part of life for my patients is not what I do for them in the hospital in the brief period of time that they're there, but actually what happens to them in their own lives, in their own homes, where they spend a majority of the time. And that's really where the challenge is. It's kind of like the Wild West. It sounds strange, but when we discharge patients from the hospital, traditionally, they just disappear into a black hole. They go somewhere. We don't really know what happens to them, and we greet them at the door when they get readmitted. But the truth is that that black hole, what happens in home, is really an area worth exploring and understanding and creating innovative programs for, because that's how we can really help people. So my patients with advanced heart failure, after hospitalization, they go home with multiple challenges. They're on a complex regimen of medications, between 6 to 8 medications. I can tell you that most of us, if we were on 1 or 2 medications, sometimes would make mistakes. Imagine being an older adult on 6 to 8 medications. They have multiple comorbidities that extend way beyond heart failure that are difficult to deal with. Their care providers don't communicate very well. The specialists, the primary care doctors, the nurses, communication often breaks down, and that presents a huge challenge. Then people have all sorts of lifestyle choices that they've had their whole life that somehow impact their disease, whether they recognize it or not. How much impact do we have on that? Very little. So as you can tell, all of these things, not surprisingly, result in these heart failure patients getting readmitted. And in fact, Medicare spends more money on the diagnosis of heart failure than any other diagnosis for this exact reason. Now, moving toward the topic of home health, there's now research that's been published in randomized clinical trial form showing that, in fact, you can provide care for heart failure patients in their own home, which is just as effective as care that we can provide for heart failure patients in clinics. This is fascinating, and it's not something that we do very much or very well yet in the United States. The article that I wrote describes a transitional care program that we founded in the Cleveland Clinic about 3 years ago called Heart Care at Home. And the focus of our program is taking care of heart failure patients as they transition from hospital to their own home. And the way our program works is we identify patients in the hospital using our electronic medical record, and then we begin an intervention that has multiple steps. Step number 1 is we have nurses who go into the patient's room in the hospital and provide coaching there. Then after the patient goes home, our team travels to the home, sees patients there, continues the coaching that we started in the hospital. They install telehealth equipment in the home, and then our team monitors them and calls them regularly for the next 30 to 40 days to provide care coordination, to help them reconcile and understand their medications, and to connect them to their doctors. And what we've seen is, first of all, an incredibly high level of patient satisfaction. They actually feel like the Cleveland Clinic and this program is at their side as they transition from hospital to home. We've also seen a trend towards reducing readmissions by several percents compared to what Medicare and others report about the Cleveland Clinic. So it's really been an exciting success, and I can tell you that we are far from making it perfect. When we started this off, we had an idea that this is the right thing to do, but there was no instruction manual about how to do it right. And there still isn't an instruction manual. We're still learning about how to do it right. So what are our challenges and what are our opportunities? First challenge has to do with communication across venues. How do we make communication completely seamless across venues? One of the things that we're going to roll out next year is a new module, a new aspect to our electronic medical record, where just like we documented in the EMR in the clinics and in the hospital, we'll be able to document in the home setting, and that communication will be seamless for all providers across the continuum. Believe it or not, it's not something that currently exists. What are other things that we're doing? We're cross-training our home-based providers to be specialists. So we have nurse practitioners who have a home care background, and we've also trained them to become specialists in heart failure. We're going to help them become specialists in stroke. We're going to help them become specialists in other surgically related areas. So therefore, we have people with high levels of expertise traveling out to see people in their own homes and to take care of them there where they want to be cared for. Finally, there are all sorts of interesting opportunities for heart failure patients when it comes to home monitoring. Right now, we monitor the most basic things. weight once a day, blood pressure once a day, heart rate once a day. Well, guess what? When you're in the hospital, we monitor you continuously, and there are all kinds of innovative ways to really get a lot more information from patients in the home and to potentially act on it. So these are things that we're learning about. One big challenge that we have, and all hospitals in the United States have, we're trying to do these kind of things, is that we have one foot in a fee-for-service world and one foot in a value-based world. So all these programs that I'm describing to you, at least at the Cleveland Clinic, we pay for them ourselves. There are no payers, Medicare or otherwise, who are willing or are able to pay for these innovative transitional care programming. So this has been a challenge that has somewhat limited our ability to rapidly grow these programs. But regardless, it's something that we're very committed to. It's something that we're going to continue growing. Our focus on home health is expanding all the time, and it's something that the Cleveland Clinic is very much committed to. Thank you.
Thanks so much, Dr. Gordesky. Just a really great overview of the emerging role of home care in the care of patients with cardiovascular disease. And your involvement and leadership is certainly really changing things at the country's best heart care program by many accounts. Margarita Lapson has another very important perspective to share on home-based palliative care.
Thank you, Dr. Landers. Good morning. And from my perspective, I am a home care nurse manager, and it's a great day to be in Washington and to be sitting on a panel with other physicians that are now talking about the value of home care and their experiences with it, because I live and work in the world of the black hole. As I said, I'm a nurse case manager. I'm also the executive director of the home care program at the Joint Commission. And the mission of the Joint Commission enterprise is to continuously improve health care for public in collaboration with stakeholders such as this panel and such as yourselves. And participating in important work such as this is one way that we're helping to deliver on that promise. For those of you that are not familiar with palliative care, its primary goal is to alleviate pain and suffering for patients who are concurrently receiving some life-prolonging or even curative care. Palliative care has become increasingly important to the care delivery in the United States, particularly as older Americans are becoming increasingly ill and the emphasis is turning to patient-centered care. Palliative care can be provided in any setting accredited or certified to provide this type of care, and it's offered today in hospitals, skilled nursing facilities, home health organizations, and in hospices. The Joint Commission accredits and or certifies providers who've been evaluated and meet standards that have been developed with input from healthcare professionals, providers, consumers, experts, and government organizations and others. And to date, I'm proud to say that the Joint Commission has certified 21 palliative care programs in various hospitals across the United States. Palliative care is often provided in the home by home health agencies. Home health care plays a critical role in improving access to palliative care. When patients have access to symptom management and pain management services in the home, the quality of life is shown to improve, particularly among patients with advancing or serious illness. This work specifically focused on home health providers can work seamlessly. The work here that we reviewed really highlights the work of home health providers working seamlessly with other providers across the healthcare continuum in offering palliative care services, improving patient satisfaction and reducing the cost. Specifically, we reviewed 2 home health-based palliative care programs that have been shown to be effective: Kaiser Permanente's in-home palliative care program and Sutter Health's Advanced Illness Management Program, otherwise known as the AIM. So the Kaiser program is called the Tricentral Palliative Care Program, was founded in 1998, and it began as actually an outpatient service that was housed in their home health department. And it was for seriously ill patients that were caught between the extremes of either too little or too much health care. It was modeled after the hospice benefit, and the program focused on quality care services and enhancing the patient's quality of life. Using an interdisciplinary approach, they delivered all of the services into the home, including physicians, spiritual counselors, as well as the full spectrum of skilled care. And in both a randomized controlled trial and comparative studies that occurred subsequent to this, there was found to be increased patient satisfaction, decrease in the number of visits to the emergency department, and a decreased rate of readmission to hospital. The median cost savings was an average of $8,000 per person. In heart failure alone, there was a reduction in readmission of 52%. The Sutter Advanced Illness Management Program, what they refer to as the AIM, began in 2000 in response to, again, a growing population of patients with advanced illness who needed advanced care planning and symptom management. As this AIM program matured, though, it evolved into a comprehensive approach to care management that means that moved the focus of advanced care planning and illness out of the hospital and into the community setting, again with some significant results. 68% fewer admissions and an average monthly cost savings of $2,000 per beneficiary. The program recently received a Center for Medicare and Medicaid Innovation Award grant to continue their important work. So under the current Medicare palliative care program, under the current Medicare system, it's offered as part of the hospice benefit. However, it's limited to care designed to make a patient more comfortable and really doesn't focus on any curative services. The Medicare program and its beneficiaries have much to gain by offering palliative services outside of the Medicare hospice benefit. And if provided in the context of a physician's broader care plan, palliative care can enhance and sometimes prolong life. The success of these two programs I've described today present many opportunities for the United States healthcare system for improving health care to patients, reducing inpatient care, and reducing the cost by preventing unwanted hospital care. Federal policy changes are needed to facilitate the close coordination needed to achieve the outcomes that I've described here and that are in the AIM program. This work indicates that until a shared risk, shared savings model replaces the current fee-for-service reimbursement model, new payment policies will be needed, at least in the interim, to pay for non-reimbursed palliative care services. As the prevalence of seniors requiring care for chronic and advanced illnesses grows, more integrated systems and increased coordination will be critical to ensuring that the quality of life for the Medicare population. Thank you, Dr. Landers.
Thank you, Margaret, and thanks for sharing your work on home-based palliative care. And I think, two things that, really wonderful things that you and your colleagues shared in your article. One is the figure that has the diagram of the role of both curative care, if you will, and palliative care. Right. And I think, I've many times felt the need to try and explain to patients and families that when we offer palliative care appropriately, we're not taking anything away, we're actually completing the whole care picture. And I think that illustration that you shared really is wonderful. And also your point about there's gaps in our ability to provide palliative care, but also there are a lot of opportunities to provide palliative care within the current home health programming. Many of the services that are needed for patients that have palliative care needs, nursing, teaching and training, observation and assessment, care plan oversight and management, are part of the home health benefit, and there are a lot of opportunities for us to do a better job incorporating those concepts into the care of patients with palliative care needs. We're going to transition into a brief discussion about the articles, and we will have a little bit of time for some questions from the audience or from our webinar participants as well. I want to go back to the topic of transitional care. All of our panelists talked about transitions of care in the context of chronic illness care, geriatric care, the care of the patient with cardiovascular disease, post-surgical patients, and so this is a real crucial area where it seems like we can make a difference in helping people get home and stay home successfully. Dr. Fleming, in your report, I almost am envisioning a model whereby the traditional role of a home care intake coordinator or liaison is being transformed into something more innovative almost. And is there an opportunity to more standardize how we do care transitions in the home health and post-acute setting?
Absolutely. I think where we have to go is to look at the way things are now. We hear all the time that healthcare is in silos, and I would disagree with that. I have a lot of time to travel around the country, and every time I see silos, I notice they all point in the same direction. Nothing in healthcare points in the same direction. In fact, it's more like a bowl of spaghetti. And so the opportunity we have here, we've been talking about this, that represents the fragmentation. And we're dealing with very vulnerable patients, particularly in our role, dealing with home health care. So if we're going to change that bowl of spaghetti into something that's truly patient-centered, then the opportunity is for us to figure out exactly what works across this transition and to make that seamless so that we don't have that fragmentation based on the patient's needs, so the patient remains in the center. So I think the opportunity there is huge for all of us. And I think one of the most important parts of that, and it's been talked about all along the whole panel, and that is that it's the team approach to work around what the patient needs. We can work together as a team much better than any of us can work individually to achieve that. So the standardization of what happens in that transition period, the standardization of the handoff, the seamless handoff, may be one of the most important things that we could do to improve outcomes, particularly for the most vulnerable older patients who have multiple chronic diseases.
Thanks for sharing that. Just a really great model and innovation and really solving a problem. Now, Dr. Bowling, in the article that you and your colleagues wrote, you really talk about a number of different home-based care models, advanced home care models, from nurse practitioner-led transitional care to home-based primary care. And I'm just curious to know if you have any predictions or see anything in the crystal ball in terms of what are going to be the most impactful models that we see a decade down the road in terms of helping people stay healthy at home.
Well, the hardest thing to predict, I guess, is the future. So the crystal ball is going to maybe be an imperfect tool. My hope, and we have some opportunity to direct the future course of events, right? My hope is that for people that are very debilitated and chronically ill, their care will mostly be delivered at home. The home will be the center place where their care is delivered, and the transient leaving of the home will be an aberrance, so that the folks taking care of the patient at home will be seen as the ones who sort of are primarily responsible for the patient, and it will likely include a variably intensive intervention that fluxes up and down according to the needs of the patient, relatively light at times, much more resource intensive, and sometimes technologically advanced at others. The patients that we've seen, and there have been many thousands that I and my staff have managed, and I've been in almost every nursing home, almost every assisted living, and an incredible variety of homes all throughout the Metro Richmond area, as have most of my crew. The thousands of patients we managed have been each different. They don't conform well to a script that you're going to write along the lines of a disease condition or something a course of events that you can predict. And so we have to design a care system that is incentivized to do the right thing, flexible and oriented really to the patient's needs. There's been a lot of talk about being patient-centered, but dragging a sick, young, old, or otherwise aged person out of their sick bed to come to a medical center venue for our convenience is not patient-centered, and it's usually not as efficient in the long run or as cost-containing with respect to how care is delivered. So I hope we're going to really transform the whole menu for 5 or 10% of the patient population that look like this.
Yeah, and that's a key point. I think that the patients that may benefit from different types of home care maybe at different phases of illness or different life phases, and for that really low mobility, high risk group, the models that you outline are really promising. Dr. Freumpson, you are the president of a hospital with arguably some of the best post-acute services, really in the community with respect to acute rehabilitation and subacute rehabilitation, and then you work with Dr. Gorodetzky's team on home-based care. How do you figure out where does a patient go when they've moved from their surgical period into that more post and aftercare period?
Yeah. So, that's a great question. And a lot of our patients really aren't sure if they're going to be ready to go home after a procedure. And an important component of that is having what we call a plan A and a plan B. And so we have a default plan which suggests that if you've been at home, you're a functioning individual in your own home, your target is that ultimately you're going to go home. The question now is when and what kind of resources and services we need to deploy before that takes place. So it can be for some of those patients that a short stay in a rehab facility or skilled nursing may be appropriate, but the idea is to couch it in terms of we know you're going to get home. Our job is to shorten the time interval that you require institutionalization, is what we call it, because we know the longer you stay in an institution, the more debilitated you get and the more depressed you get, and you're really going to be happier going home. The second part of that is that we really need to improve the home environment. When we talk about healthcare facilities, we talk about the facilities, the people, and the information that we convey, and we don't often look at the patient's home and talk about how are we going to improve their home. So are we going to go out and install some rails in the bathroom? Are we going to make it a safer environment? And then are we going to get the people, their neighbors, their friends, their family, to enable that to be a safe transition? So it's a detailed but comprehensive program that I think then helps us prevent them from coming back prematurely or being readmitted.
It's fascinating that you bring that up about improving the home, and I know one of our colleagues, Bruce Leff, often talks about the concept of architectural malpractice, and the idea that the one that strikes me is if you ever made a home visit in a split level home where you open the door and you got two choices, go up or down steps, what implications that might have for somebody when they have a mobility limiting medical condition. What barriers do you see in getting more people at home, and what can we do to bring those down?
Yeah, so one of the things that we've looked at is how do we get that preoperative home visit? So that's a huge barrier because people haven't thought about, they've been living in their homes for decades, they really haven't thought about whether they're safe environments, and they're often, if you go in there, you find they're really not safe. And so one of the challenges, there's no way to get payment or reimbursement for that preoperative home safety assessment, which I think would be a really key move for us to enable more patients to get home safely.
Great. Well, I've got two tough questions for Dr. Gorodetzky, and we'll give you a choice of which one you think is easier. One is, how do we prevent readmissions for patients with heart disease, and how can home care providers, do a better job in making sure that we keep people healthy at home? And the other one is, what's the role of home care, not via the front door, but through telehealth devices and virtual encounters with video? So we just need to solve readmissions and also figure out the role of technology in keeping people at home. And we have about 30 seconds before we're going to go to the folks in the audience.
Well, I'm going to take a few more seconds than 30, but before I even touch those questions, I want to say that the whole issue of readmissions is very controversial within the cardiovascular community. On the one hand, everybody agrees that readmissions, especially for patients with heart failure, are very costly, and this is a viable target for a way to reduce costs. If we can reduce readmissions, if we can reduce costs. Another part of the argument is the question of, does readmissions for heart failure actually represent a quality metric? And sometimes those things are very interchangeable. There's some data suggesting that for heart failure, in fact, hospitals that have higher readmission rates may have lower mortality rates, an inverse association. And this data, in a recent publication, was demonstrated to hold water, to be accurate. The relationship was modest, but it was real. So is readmissions an excellent quality metric? My opinion is it's not a great quality metric. It's not like when you leave a sponge in somebody's body after surgery or when somebody catches an infection. Sometimes a readmission is an appropriate thing, and it's the right thing to do for patients. When it comes to heart failure, approximately somewhere between 25 and 30% of readmissions for heart failure are potentially preventable. Okay, only about 25 to 30%. That means that we're never going to be able to bring that number down, or do we want to bring that number down to 0%? As far as preventable readmissions go, there are a lot of excellent opportunities, many of which are focused on the home environment. What I've seen and what I've learned is that if we can come up with innovative programming, innovative care transitions programs, ways to bring more specialized providers to people's homes to address some of these issues, including poor care coordination, problems with medication reconciliation. Those are ways that we could potentially reduce readmissions. I think that telehealth and video conferencing is an exciting thing to think about. We've recently finished a pilot at Cleveland Clinic where we took patients who just underwent heart surgery, bypass surgery or valve surgery, and in addition to a standard visit with a nurse practitioner after surgery, we also gave them tablets that allowed them to have virtual video visits with nurse practitioners from their own home. And what we discovered is that patients loved this. They took it very seriously. They felt a lot more connected to the healthcare system. And the feedback we got from the nurse practitioners who did this intervention is that a picture is worth 1,000 words. You know, you can talk to people on the phone, but if you can see the way they're breathing, the way they're sitting, the color of their skin, you get much more of an insight about their condition than you would on the phone. And in fact, some of the feedback that we got was nurse practitioners who otherwise would have given instruction to the patient to go to the ER because they were complaining about something, after a video interaction, they were able to say, you know what, you don't look so bad. Why don't you stay at home and come to see us in clinic tomorrow? So I think that these are areas that are worth exploring further. I think they're exciting. I think they're futuristic. And they demonstrate what kind of promise we have for taking care of people in their own home using innovative technology.
Great. Thanks so much. I want to move to our audience here at the office building, and we have Emily here with the microphone. If there were any questions from the audience, I think we have one up front here. And if you could introduce yourself.
Absolutely. My name is Dominic Kennerson. I'm with Wyatt Modesty Healthcare Investment Bank. I have two questions related to innovation. The first question relates a little bit to Dr. Gorodeski and his thoughts about comorbidity. And I'm really curious about the integration of behavioral health and physical health in the home and how that plays out and how you see that playing out. And then we've heard a lot today about the CMMI grant and what that means. And so what I'm really curious about right there, the Amedisys program that you have with, I believe it's the Heritage Group Health Innovation Fund. And if you see strategic investors playing a larger role in the home health marketplace and what that can mean for everyone. Thanks.
Well, so that was, you touched on many aspects of home care, the role of behavioral health in a more holistic view, as well as innovation and opportunities for business. And I think, Dr. Bowling, if you could maybe comment on those areas and what participants might be thinking or want to think about.
Sure, and I'd welcome input from the other panelists as well, especially the Amedisys program. I would defer to Michael on that. Briefly on behavioral health, though, it is very important to be comprehensive and holistic in our approach to the patient care for most of the patients that we see in these programs. And there are some patients who are very well adjusted and balanced, and it's really all about medical care and management. But I would say in at least a solid minority, if not even a small majority of patients, there are issues related to chronic mental illness of one sort or another, simple depression, dementia and its complications, more significant chronic mental illnesses that contribute a great deal to the difficulty in managing and stabilizing and helping these folks, or similarly helping their families, because there's oftentimes an interplay there, and there's actually a pretty big gulf in terms of the availability of mental health and psychological services in the home that we're struggling all the time to fill.
Thanks. And Dr. Fleming?
Yeah, I think it's a good question. I think the fact is that there's a lot of interest in looking at the home as a different place of health care. I think that the healthcare system that we've had previously with more facility-based care, we have a different world right now. We have a different demographic, and we have many people with chronic diseases instead of necessarily the acute diseases that have afflicted us in the past. And because that world of chronic disease needs management, not episodic care, but management over the continuum of care. And it makes sense that the home is the place that for most people to receive that care. You recognize that 5% of Medicare patients account for 49% of all Medicare costs. So if we're going to focus on that 5%, it's those with chronic diseases. So I think that's why Amedisys is interested in things like the Heritage Healthcare Innovation Fund. And I think that that's an example of a lot of people are going to be focusing on this concept of healthcare in the home as the real innovation in managing these chronically ill people and in reducing costs.
I want to take a question from our Twitter feed that came to me via carrier pigeon here. But it originated on Twitter. And the question, actually, it's a technology-related question that I think a number of our panelists, Margarita Labsid in particular, might want to first comment on. How do you see point-of-care devices and other technology affecting the home care sector as a whole? You've probably seen a lot of examples of this throughout the country, and maybe could share a broad view.
Sure, I'd be happy to. I think technology is going to be a great augmenter. I don't know if it's ever going to take the place entirely of that relationship building, but it will enhance the ability of a caregiver to maintain a therapeutic relationship with their patients, and that's really its great advantage. It also brings in that third, what we say, the third leg of the stool. The third leg being the patient being engaged in their own process with the ability of social media, the ability to sit in front of their computer screen and talk with their caregivers, as well as bringing the families in so you can have virtual care conferences with patients that I come from Florida. They're spread out all over the country. That social media is really, I think it'll take it to a new dimension.
Thank you, and I think that's a good point. I shared a piece about technology, and I think that in our organization in New Jersey, we have hundreds of clinicians out in the field with a Samsung Galaxy Tab with a mobile broadband connection as their point of care system. Right now, we're using that for documentation, for record review, for communication. I think ultimately that same type of device will serve as a platform for potentially clinician-to-clinician consultation models, for other types of programs and applications that can be brought to the point of care. I think there's great opportunity there. I'm going to take one more question from our audience. Our audience participating via webinar, but then we'll have to close our panel. Unfortunately, we've come up against the hour. But one of the questions, I think, Dr. Bowling, if you could address this, it's as Congress grapples with the Medicare program's costs, the VA Veterans Administration's home-based primary care program seems to be an intriguing model because it's reduced costs by providing chronic care management services in the home. Do you think that Veterans Affairs like home-based primary care program would be worth examining as a model for achieving savings without harming seniors?
Well, Steve, I feel I'm grateful for the question. When we pursued the passage of the Independence at Home Act through the House and the Senate, and then working its way into the Accountable Care Act, one of the very important sources of information we used was the experience of the VA home-based primary care program. And we brought data from over 25,000 participants over a span of years, where using prospective modeling and other tools to identify the likely costs and then looking at the actual costs of patients served, there was consistent reduction in overall costs for this patient group, which was a very high cost, high risk patient group, by 20%, maybe 25%. If you allow for the people using the VA benefit and the Medicare benefit, still 16% reduction in overall costs. And so the evidence over time from that program, which is now systematically implemented in centers all over the country, has been really very substantial and convincing to me. And it was convincing to a lot of other people as well that we spoke with. There are still questions to be answered as to how we can translate practices that are developed within the unique structure and design of the VA health system into the larger environment where it's more heterogeneous. But I'm completely sure that there's an opportunity. I'm convinced without a doubt in my mind that that can be done. And I do think this is an opportunity for Congress to look at as one of the solutions to the challenges that we all face and I think are legitimately concerned about.
Thank you. And I just want to take a moment to thank all of our authors and panelists for the work that they've done. They really represent teams of many people back in their home organizations that have been spending years, if not decades, working on trying to figure out how do we help people stay healthy at home, how do we help family caregivers when they've got this 168-hour-a-week struggle, how do we best support those, I call them the hidden angels of the health system, those home care nurses and aides and therapists out there dodging the snowflakes and the stray dogs, trying to figure out how to help people stay home. And the work that was presented today, I think, is going to make a big difference in helping those families, helping those dedicated clinicians and caregivers succeed. So thank you. It's been an honor to be here. Thank our participants from the audience. It's been a wonderful morning.